This is a valuable topic on how to preserve your fertility and how to save your fertility for down the road. At this time, I'd like to introduce to you Jeanette Tomasino. She is the Senior Director of Nurse Education at EggBanxx, part of Progyny. She's actually got nearly 30 years of experience in the reproductive medicine field and has served some time at Cornell. Jeanette, it's all yours.
Yep.
Okay, so thank you, Dale, for that introduction. Yeah, I spent 28 years at the Cornell Center for Reproductive Medicine as their clinical educator. Please don't try and guess my age, because I started working there when I was 5. But anyway, over the last 28 years, I've seen so many incredible advancements in technology, and most specifically in our egg freezing, our vitrification process. So that's why we're here today. We have more options. So I want to go through the slides. My goal today is information and empowerment. I want to finish up maybe a little bit early, so I'd be happy to take questions from the audience. So this is my disclosure slide. So the outline of my talk today is going to start with, I'm going to do it now what? I'm going to talk about your initial consultation, the stimulation, egg retrieval, and freezing. And then we'll talk about when you're ready to come back to use your eggs, how to go about that. And then finally, I'll just tell you a little bit about EggBanxx. So everyone's reason to freeze is different. Ultimately, the goal is to maximize their chances of having a healthy baby when they're ready. So Dr. Allering spoke a little bit about this. You know, when I talk to my patients, why should they freeze? Humans are not very efficient at reproduction. We're not like puppies. You know, as you know, we get older, it gets harder and harder, but we're just not very efficient. If you look at this 30-year-old woman here on the bottom, perfectly timed intercourse for a woman is only a 20% chance of conception each month. And see what happens as we get to age 40. Over age 40, it's about 5%. So this is why we should consider thinking about preserving our fertility. So where do you begin when you want to do egg freezing? It starts with the initial consultation, and Dr. Allering had touched on this before in his previous talk about the ovarian reserve testing. We do routine blood work and cervical cultures. At Cornell, we used to require a meeting with a psychologist. It was optional. You would go through an injection teaching class, and then your nurse will order your medications. So we heard about this in the previous talk. The anti-Müllerian hormone is produced by the granulosa cells in the ovarian follicles. The AMH levels reflect the size of the remaining egg supply. So the more follicles you have, the higher AMH is. Normal AMH is 1 to 3. They also check your FSH. Now the menstrual cycle begins in the brain. The pituitary gland sends FSH to the ovary. Each month that ovary is supposed to respond and produce a follicle. When that ovarian reserve starts to diminish, the FSH signal has to get very strong in order for that egg, that hormone, for that ovary to recruit a follicle. So we want a high AMH and a low FSH. The best indicator of ovarian reserve is that ultrasound, when we count those tiny little follicles on the ovary. So again, here we see the AMH starts to diminish. After age 35, we really start to see a decline in our fertility. We spoke about this in the previous cycle. The previous talk was the antral follicle count. So we count those tiny little dormant follicles in the ovary. And again, this is our best determination of what the ovarian reserve is actually by looking at those follicles and counting them on each right and left ovary. So when you want to do egg freezing, what's involved? The first part is ovarian stimulation, and that can take anywhere from 8 to 14 days of taking daily blood work and ultrasounds and doing the injections in the evening. So it's going to be a 2-week commitment should you decide to do the egg freezing. Once your doctors decide that those eggs or those follicles have reached the right size, we're going to prescribe a trigger shot in preparation for the egg retrieval. And then the eggs are harvested on that particular day and frozen the same day until you're ready to use them. Most of our doctors want to see you about a week early just to make sure that everything is back to normal. So your doctor may prescribe a combination of any of these medications. Some of the women that I treat are on anywhere from 2 to 3 injections a night prior to the trigger shot. So this is what scares most people who go through the egg freezing, or those needles, those injections. The injections are very small. I think there's something more psychological about sticking yourself with a sharp object, but the first night's usually the hardest, but you do get over that. So you can see on this particular pen, there are numbers there. You're going to dial your dose from night to night. So what you're doing is going in the morning, having your blood assessed, your ultrasounds, and then your nurse at the center will call you and tell you how much medication to take. So these are multi-dose pens. You're going to use them throughout the course of your cycle, but the dosage will be adjusted. So the ovarian stimulation is the first part of this. Your cycle usually begins on day 2 of your period. Sometimes we prescribe birth control pills in order to get you ready for the egg freezing process. A lot of women say, why do I have to be on birth control pills? It's for timing purposes and to get everything in the right place, everything nice and suppressed so we can start you on these medications. Typically, it takes 8 to 14 days. It is a commitment for those 2 weeks. I think a lot of women like to have the clinics nearby their workplace so they can come in for monitoring and get to work. But it is almost daily blood work and ultrasound. And our goal is to get the follicle size to be about 17 to 20 millimeters in size. You don't want to trigger too soon and have immature eggs, but you don't want to wait too long. So these follicles grow by 2 millimeters a day, and we can kind of guesstimate how far away you are from the egg retrieval. From the time that my patients start their injections, I ask them not to exercise, to avoid high impact exercise. The ovaries are going to be very heavy. They become weighted down, okay? We don't want you in the gym where your ovaries are flipping around. So we ask you to avoid high impact exercise. There's a very small blood supply that supplies the ovary. We don't want that ovary to flip or twist on that blood supply. The other thing we ask you is to avoid any pain medications such as aspirin, ibuprofen, Aleve, because we're going to the operating room, we don't want anyone bleeding. So some women get headaches from the hormones, so you can take Tylenol as needed, but avoid aspirin products. So these are the injection sites. The first part of this, you'll only be doing subcutaneous injections. If you were doing the full IVF where you're having an embryo transfer, we get into the larger injections. But for the egg freezing, it's these small subcutaneous injections. So anywhere below the lower abdomen or the upper outer thigh, and you're going to rotate your injection sites nightly. There is not one site that's better than the other, but you don't want to go in the same spot every night. So this is a nicely stimulated ovary, and you can see those black circles there. Those are the follicles. Inside those follicles is fluid, and the egg is floating around in the fluid. So these follicles are estrogen-making machines. As those follicles start to grow, you're going to see rising levels of estrogen, and we're going to start to decrease your dose of the hormones. Okay, but our goal is to get those follicles to reach around 17 to 20 millimeters in size, and when we go for the egg retrieval, they actually puncture each one of those little pockets of fluid and collect the eggs. So your doctor will evaluate your blood test results and ultrasounds and make protocol decisions. Every time you come in, your nurse is going to call you with your medication dose, when to come back for monitoring, and the timing of the egg retrieval. Our daily requirement is so important while you're going through the egg freezing because we don't want to hyperstimulate you or give you too much medication where your ovaries become very swollen and you start to have fluid in the abdomen, but we don't want to understimulate you that you don't get enough eggs, okay? So we're constantly checking and balancing your hormone levels, calling you and telling you how much medication to take. So everyone wants to know what's going to happen to me. Am I going to go crazy on these hormones? I don't think anyone really, some hormonal issues, but nothing too crazy. You may have some discomfort or irritation at the injection site. I always ask my patients to drink water to hydrate for the blood draws because after 2 weeks you get kind of sore. As those ovaries become enlarged, you may have some bloating, weight gain, fatigue, mood swings, or headaches. Please contact your doctor or your nurse if your symptoms are severe. So once your doctors have decided your follicles have reached the mature state, he's going to prescribe, or she's going to prescribe HCG. This is a timed injection that prepares you for the egg retrieval about 36 hours later. You'll be given an exact time to take these injections. When you're doing the first part, the stimulating medications, we ask you to be within an hour, try and be consistent. When I schedule HCG shots at my clinic, I do it at 15-minute intervals. So if I'm 9:30 p.m., the next one will be 9:45. That's going to be our lineup in the operating room. So the HCG is a timed injection in preparation for the egg retrieval. The night that you take your HCG, there's no longer any stimulation medications. So the morning after the trigger shot, so the timing is a 36-hour window. So if I was going to trigger HCG tonight, Saturday night, I'm going to be in retrieval Monday morning. But the morning following the trigger shot, most centers have a pre-op visit where you'll complete hospital paperwork and consents. You'll receive instructions for the egg retrieval. You will have an ultrasound and physical exam. The only day that you need to take off is the day of the egg retrieval. Okay? During the whole process stimulation, you can go back and forth to work as long as you leave your mornings open for monitoring. You will be given usually IV sedation. We give midazolam or propofol. So the recovery time is about an hour. The procedure itself is only 15 minutes, but you do need an adult to escort you home. So, as Dale said, I've been in this field almost 3 decades. When I started, they used to do abdominal egg retrieval. Now we do a transvaginal ultrasound-guided needle aspiration. So you're going to have 2 small puncture sites in the upper outer vaginal wall, and this needle aspirates the follicular fluid, and inside that fluid are the eggs. So there's 2 puncture sites inside the vagina. After the egg retrieval, we only give Tylenol. Okay? So there is some cramping and some spotting, but just Tylenol after the egg retrieval procedure. And again, it's only about 15 minutes. It's the recovery time that can take a little bit longer from the anesthesia. And these are the egg collection tubes. So after the REI physician finishes, the circulating nurse takes those collection tubes to the embryologist, and then they start sorting the eggs. So the day of your egg retrieval, you're going to arrive at your center at your assigned time. The egg retrieval is performed by an attending physician. So this is at Cornell. We have lots of training fellows. We have our attendings only doing the egg retrieval. The IV sedation is administered by an anesthesiologist. The procedure takes about 15 minutes. The rest period in the recovery room is about 1 hour. And again, you must be accompanied with an adult to be discharged. So after the egg retrieval, we usually admit our patients early in the morning around 8 o'clock, and they're home by lunchtime, but we ask you to rest as much as possible that day. You may have some cramping, spotting, or bloating. This is normal. Take Tylenol as needed. You should call your physician if you experience severe symptoms such as fever, excessive bleeding, or abdominal pain. After the egg retrieval, you're going to have 2 small puncture sites in the vaginal wall, so we ask you not to have any intercourse or swimming or tampons for about 2 weeks until that heals. Again, you're going to also avoid strenuous exercise until those ovaries get back to normal. So from start to finish, this is a 28-day cycle. Okay? You will be given written post-operative instructions from your fertility center. So the following day, our center will call you and tell you how many eggs retrieved. We'll tell you the number of eggs retrieved and the number that were mature. So sometimes in the egg collection process, we can get some immature eggs. Those will not be kept in frozen because they cannot be fertilized. Okay? The following day after the procedure, you still may have some light vaginal bleeding, spotting, soreness, cramping, or bloating. So this is a nice picture of an oocyte, that's the word for the egg. And how do we know that it's mature? By that little cap on top, that's called a polar body. That's what the embryologist is looking for. When I teach the nurses, I show them this egg and I say, this is the largest cell in the human body with the highest water content. Years ago, when we used to do slow freezing, it was like putting an ice cube into a freezer with water. So what happens to that water is it expands and contracts, and then there were crystals inside that were like microblades that were piercing the cell, the egg itself. So we had really poor success rates freezing eggs with slow freezing, but now we do vitrification, which is a flash freeze in liquid nitrogen. So we don't have all that cellular damage from the ice crystal formation. In 2012, the American Society of Reproductive Medicine said vitrification is no longer experimental. So now our survival rates for egg freezing are the same as embryos, about 70 to 90% survival. So your eggs are frozen the day of the egg retrieval, and again, we're going to sort them out. We're only going to take the mature eggs by vitrification, so which literally means your eggs are in a glass-like state, and the eggs are stored in liquid nitrogen for future use. So again, as I said, it's no longer considered experimental. We spoke about vitrification versus the old way of slow freezing. The data suggests that 8 mature eggs available per thaw allows for pregnancy rates comparable to IVF. The average 35-year-old patient needs about 1.2 egg retrieval procedures to bank a total of 16 eggs to allow her for 2 thaw cycles. So sometimes, if you don't get a high enough egg yield, your doctor may recommend doing another cycle just to bank more eggs. Data suggests freezing eggs for personal use should be done before age 37 because I showed you that chart, how our ovarian reserve starts to diminish in our egg quality after age of 35. When I speak to my patients who want to do freezing, I also discuss with them other options such as natural concession, donor egg, and donor sperm. So this is a nice picture of 2 oocytes contracting as they're freezing. They're rapidly frozen. So we have no ice crystal formation. And this is expansion as it thaws. So your eggs are stored until you're ready to use them or decide on their use or disposition. So sometimes women do this as a backup plan and they don't need to use their eggs. So in our consent forms at Cornell, we ask you to decide on their disposition in the event that you don't use your eggs. and your options are to discard them or donate them to research. Okay? If you wanted to donate them to another person, it's a little more involved because it involves FDA screening and testing. Okay, so this is your options here. And you also have the ability to transport your eggs to another facility as long as it's within the domestic United States for continued storage. So when you're ready to use your eggs, you can either use sperm from a partner or donor sperm. You're going to consult with your doctor. You're going to require prerequisite testing. So what we do when you come back to use your eggs, we're going to program the uterus with estrogen and progesterone. We're going to make a nice uterine environment. Then the embryologist is going to thaw and fertilize your eggs and transfer them back into the uterus. The procedure that we fertilize the egg is called ICSI. It's an intracytoplasmic sperm injection. You can see here. And this was discovered quite by mistake at Cornell. We used to do a zona drilling where they drill a little hole on the outside, and one of our doctors, Dr. Palermo, he was doing research in Holland, accidentally punctured the egg and thought that was no good, put the egg aside, and 3 days later it was an embryo. Okay, so now everyone, or most everyone, is doing ICSI. We usually do ICSI after an egg freeze because the thawing and freezing process can make the outer shell of the egg a little bit tough, so we make sure that fertilization happens with that egg. Okay, so here's fertilization. So the ICSI, it's all done micro-robotically. It's almost like a video game when they do the egg procedure. But what the embryologist is looking for the next day is a 2 pronucleus. This is a fertilized egg. Okay, so at EggBanxx, EggBanxx is it provides, it's a network of fertility doctors that specialize in egg freezing in your area. So what we do at EggBanxx is we do the homework for you as opposed to you having to do a Google search and trying to find a fertility specialist in your area. They also offer savings, exclusive savings, and financing if you should need it. So our goal is to make this accessible to everybody. It's an expense that we want all women to have the option to preserve their fertility and freeze their eggs. Thank you so much. I want to take questions from the audience. Does anyone have questions about this egg freezing process? Yeah?
I do. If you freeze the eggs and then you thaw them and fertilize them, can you then refreeze the embryo?
Yeah, so that's a very good question. So sometimes women want to do genetic screening on their embryos. So we thaw their eggs, we freeze them, we grow them out, we biopsy them, and then we freeze embryos until those results are in. That's a very good question. So there's no harm in vitrifying or freezing.
Okay.
Yes. Right. Questions? Yes, and agree.
How much does it cost, like, yearly to keep your eggs frozen?
So it varies from center to center. I've seen anywhere from 8,000 to 12,000. So that's, you know, what my company is. It's so important for me for everyone to have access to this, you know, to have this option. But it's anywhere from 8,000 to 12,000. So that's for the IVF part, and then when you come back to do that, we call it an FOT cycle, frozen oocyte thaw. That's an additional expense, but not as much. Yeah, that's a good question. Any more questions?
How do you thaw the eggs?
There's a whole process. It's a slow thing where they bring it back to room temperature.
How long does that take?
We thaw eggs that day. So we thaw eggs the day, we fertilize them, and then we do the embryo transfer 3 days later. Yeah. Questions? Okay, well, and thank you so much. If you're interested, I did leave some brochures on the egg freezing at the MCRM booth there. You can just take it. Okay, thank you so much.